is. All right, good morning, everybody. Welcome to this week's AMSSM Sports Ultrasound case series. Before I introduce our speaker, just one quick housekeeping note. We will be off next week, and then on the 19th of February, we'll be transitioning a bit to our sports medicine fellow presentation. So Dr. Allison Schrader will be talking about proximal hamstring tendinosis again on the 19th, and then fellows will continue to present over the course of the next 6 months until we switch back over to staff presentations sometime late next summer or early fall. So our speaker today, it's my pleasure to introduce Dr. Brennan Boettcher. He and I have known each other for quite some time now. He had the unfortunate experience of participating in residency with me at Mayo. He did his sports medicine fellowship afterwards at Mayo Clinic Square, and he's now in practice at Summit Orthopedics in Minnesota. I have plenty of other stories about Brennan, and if anybody wants any for their private library, I'm happy to chat off air. But with that, and for the sake of time, I will pass this over to Brennan.
All right, thanks, Ryan. All right, Ryan, are you about to give me, can you give me the sharing ability? There we go.
There you go.
All right, are you guys able to see this? Do you need to flip them, Ryan?
Yeah, flip them. There you go.
Okay, is that better?
Yeah,
okay,
perfect.
All right, so I'll get moving. I know everyone has something to get to after this, and we only have about 30 minutes. So my case is a 62-year-old female with a chief complaint of a stuck finger. I don't have any disclosures, unfortunately. Our objectives, I'll just leave them up briefly here, but really it's just to go through a protocol of how do you examine the digits in kind of a complete sort of manner, and then just review some pathology relevant to this case, and then discuss the contents of a diagnostic ultrasound report. I just want to acknowledge, a lot of my mentors, Ryan Cruz, who introduced me, and Ryan Woods, bear the brunt of my clinical questions and ultrasound questions, and then also Derek and Doug for just doing such a great job with the Sports Ultrasound Committee and kind of leading the way here and producing a lot of great content, by these webinars and then also the annual meetings. So moving on, our digit protocol, we don't really have an official protocol for a complete examination of the digits. But if you look at the CMS definition, really what it comes down to is that you need to look at the joint space and the related periarticular soft tissue structures. And so you're looking at muscles, tendons, ligaments, nerves, bursa, synovium, blood vessels as appropriate. And so that's really where you get into a complete examination. If you look at the limited examination, on the bottom, and let me see if I can get you guys to see my my pointer. It won't let me. Can you see my mouse, Ryan?
Yeah, we can see it.
Okay, perfect. So if you look at the bottom here, you'll see that these limited evaluations are for really one particular structure, and so that's like you're looking at the Achilles tendon, or you're looking at the biceps tendon, or something like that. And so that, doesn't apply here. And so with our case, we have a 62-year-old female. She has insidious onset of her middle finger getting stuck. And this has been gradually worsening. It's been several months. It's worse in the morning. She notes that she wakes up in her hand. She tries to open her hand and her finger is sometimes completely stuck, and she has to use her other hand to manually straighten that middle finger. And so she's referred to non-operative sports medicine for evaluation and treatment. On examination, really the pertinent examination details are that she's able to make a full fist, her finger alignment is good, and she has full extension of all of her fingers. When she goes to straighten her finger, she has kind of a lag with extension in the middle finger, and then she has kind of a quick catch up and a subtle snap. On palpation, she has a sliding nodule at the volar MP region in the middle finger. She has similar finding to a smaller degree in the ring finger, and she reports tenderness over the volar MP region in the middle finger. No findings of Dupuytren's disease on examination, and there's no obvious tendon dislocation or snapping over the PIP joint. My protocol for digit ultrasound is really, you have to use a high frequency linear transducer. So I use a 418. And then, you know, I'd say a hockey stick is useful, maybe borderline necessary for finger ultrasound, especially interventionally. And then, you know, with dynamic imaging, it's also super helpful. You can do multiple patient positions. I typically have people sit across from me with kind of a tray in between us that they can rest their hand on. You can also have them lying with their hand on their side, which, you know, for some people who have some needle phobia might be helpful if you end up doing a procedure. If they have finger contractures, you can use a water bath. So you can use kind of a basin and fill it up with warm water. And then you can place your transducer in a transducer cover so you don't immerse the connection. And then really the big thing to know and to really pay attention to is that it can be very difficult, especially with kind of small structures and curved slippery surfaces and gel. And some people have really kind of knobby knuckles, and it can be really hard to get good contact and maintain good contact, especially through a dynamic exam. So it takes, you know, some practice. And then, you know, especially contrary to last week's exam, which was like the posterior hip, you know, body habitus doesn't really affect ultrasound quality. And in fact, some people that kind of have a little bit more beefiness, maybe it's actually a little bit easier because their knuckles aren't quite so knobby. My protocol is the following, and this is what I do anytime I'm ultrasounding a finger, and then I'll add in additional structures as are indicated. And so for the extensor tendon, you know, the central slip, you definitely want to look at that. You want to look at the distal insertion, and then you want to look at that tendon over the MCP joint dynamically for subluxation. You look at the MCP joint, including the volar plate. You look for osteophyte, synovitis. PIP joint, DIP joint, kind of similar things you're looking for, you know, arthritic type changes, loose bodies, osteophytes, anything that would cause snapping. We'll look at the flexor tendon. You'll kind of want to examine that whole course, and then dynamically you'll look at it for triggering. You'll look at the distal insertions, both FDS and FDP. You look at the A1 pulley and A2 pulley, the digital nerves, arteries, you know, especially if there's any questionable laceration. And then you can look at collateral ligaments kind of as indicated in a little bit, depending on where you are. Prior to that, you know, you want to look at radiographs for arthritis, fractures, you know, loose bodies, which can be helpful. And so kind of getting into the evaluation. So really with the extensor tendon, the first thing I'm going to do is kind of look at a long axis view of the MCP joint, the central slip, the distal insertion, and then the lateral bands if clinically indicated. And then in a short axis view, I'll look at that over the MCP joint and with dynamic examination. And so just to kind of go through that. So when you're looking at that extensor tendon, you know, you can kind of sweep from the metacarpal level over the MCP joint, following it distal, and then towards the distal insertion. You can follow it kind of the whole way there. Over the middle phalanx, you kind of lose it for a little while as the lateral bands reconverge. And then, you know, from an anatomy standpoint, this is going to be kind of at the MCP joint level, and you're going to have that extensor tendon sitting kind of centrally, and then you'll have your sagittal bands running off the side. And this is kind of depicted here. These sagittal bands run all the way down and actually kind of attach along the volar plate and kind of form a loop or a hoop around. And you can see how, you know, incompetence of one of these could lead to dislocation. You'll do that at dynamic examination. This is one of the ones that can be difficult sometimes. And so you'll have them seated or lying down, and you'll just be in an axial plane across their MCP joint, and you'll just try and stay on the extensor tendon as they slowly make a fist with their hand. And what you're looking for while they do that is for that central tendon, or for that extensor tendon to kind of stay centrally located over the joint surface. And so that is a normal dynamic examination. You're going to look at the central slip, so distal to the right here. You're going to look at that central slip attach here on the middle phalanx, and then you'll look at that distal insertion here on the distal phalanx. And you'll note that those are both intact, and you can examine those both dynamically as well. When you look at the MCP joint, you know, you're going to look for any cartilage changes, erosions, osteophytes, periarticular cysts, any snapping tissue, and then the volar plate. And I'll typically kind of get like a little bit of a maybe 10,000 foot view with this, and kind of do a sweep around. And so, And so I'll start in long axis over the joint here, and then I'll kind of switch and pop into short axis over the joint, since it's more of an axial plane, and kind of scan back and forth between the proximal phalanx and metacarpal. And you're looking at, you know, the bony surfaces. You can assess kind of this portion of things right here in the dorsal joint for synovitis, and so you'll look for thickened tissue there. And if you put Doppler on, you can assess for hyperemia, and this is really excellent for looking at inflammatory type conditions. And a couple weeks ago, if you saw Jeremiah Ray's talk on the Achilles, he kind of mentioned a great technique for zeroing that Doppler. And so you can go back and review his talk and kind of see that as a good way to kind of make sure you're not overgaining your Doppler. When you go to the volar aspect of the joint, you're going to look at that flexor tendon, you know, from distal to the right, proximal to the left, the flexor tendon over the top of that joint. And then really, probably more appropriately, you're looking for, is there a joint effusion extending into the joint recess, which was proximal? Is there any changes are there any changes in the cartilage here or the volar plate here? And so you can examine those dynamically, and you can assess that volar plate kind of tensioning with finger flexion extension, and that's a passive flexion extension generally. Going to the PIP joint, you're looking for osteophytes, you know, effusion. This is all kind of the same sort of stuff with the periarticular evaluation. And so, you know, once again, looking at the volar aspect of the joint, you're going to look for, let's see, is the volar plate appearing intact? Are there any changes with that? You can examine it dynamically, and then looking at the dorsal joint surface as well. Same thing with the DIP joint. I won't spend too much time on these. You know, you're looking deep to the flexor tendon and distal insertion here on the volar aspect, and then same thing on the dorsal aspect. All right, moving over to the flexor tendon. So with the flexor tendons, this is, you know, generally one of the two places that I spend most of my time on when I'm doing finger exams. The other one is the extensor tendon. And so I typically say, you know, these should be evaluated from the palm to the distal insertion. And so I typically start where my carpal tunnel evaluation ends, and then I scan them to their distal insertion. And I think, you know, you want both short axis and long axis views, and then you want dynamic views, definitely, if you're looking at the finger. And you want to get each distal insertion, so the FDF and FDP. And so I'll kind of go through a couple of kind of just straightforward, this is the anatomy sort of examples here first. And so first I start with this sweep, kind of starting, this is right at the metacarpal, the MCP joint level. And so I'll kind of just sweep the tendon distally. And with that, I kind of get a just general overview. Do I see any cysts popping up on either side, superficial or deep to the tendon? Do I see anything real abnormal, a large tendon sheath effusion, significant synovitis? Does significant pulley thickening catch my eye? And so this is just kind of a where is home base sort of picture. When you look at the anatomy, you know, this was one of the things that probably took me the longest when I first started doing hand ultrasound to really understand, you know, the relationship between the pulleys and the tendons and the anatomy of each of the tendons. So, you know, starting in the level at the level of metacarpal, the FDS is going to be primarily a solitary, more or less superficial tendon with the FDP being deep. As you pass between the A1 and A2, that FDS tendon starts to kind of split into two separate bundles. And so you have this one kind of radial, one ulnar sort of bundle, and you'll see them separating around. And as you pass through the A2, and I'll show you some videos of this, you'll see that tendon wrap around and head down towards this insertion on the middle phalanx, kind of around the A4 pulley region. And so just kind of normal long axis evaluation of these tendons. So this is the distal insertion on the distal phalanx here. And so you can, you know, evaluate for a jersey finger or anything like that in this region. You can see the A4 pulley sitting here. Once again, distal to the left in here. So this is the flexor tendon over the middle phalanx level. And once again, you see that A4 pulley kind of located centrally. You're looking around the tendon. Is there any significant fusion or tenosynovial thickening? Moving proximal over the PIP joint, once again, distal to the left. You're going to look at that tendon coming up over the volar plate and over the joint. You can see that part of the A2 pulley here, and the A4 pulley is going to be to the left. And once again here, you're kind of just looking for, does the tendon have kind of a nice fibular pattern? You'll notice that the tendon changes angle several times here. And so you end up getting some kind of differential anisotropy. And so you usually have to kind of go back and forth and do some heel toe maneuvers to really bring in the entire tendon. And it can be hard to do it on just one static image. Looking at the FDS insertion, and so this is going to be kind of the radial insertion of the FDS, so it's kind of coming obliquely and extending down adjacent to the FDP tendon, and it's really going to be kind of more dorsal at this point to the FDP tendon, and inserting onto the middle phalanx, essentially right here being the footprint. And then same thing, this is kind of a short axis view of that FDS outlined on the middle phalanx, with the FDP tendon kind of being more volar. And then here, this is the ulnar side, and so you'll see that that tendon is slipped, kind of wrap around and extend down from the kind of proper tendon itself. All right, so back to our case. So when we're looking at this patient, distally everything was normal. Over the middle phalanx, everything was normal. And then when you get over the MCP joint, things don't look quite as normal. And so this is the patient's finger with a hockey stick transducer. And so I typically switch to that for these dynamic examinations. And as she tries to extend her finger, you'll see that flexor tendon bunch up. And so this is going from a flexed to an extended position, so distal to the right. And as the tendon bunches up, you'll see there's some differential motion between the FDP, which is about the deep 50 or 60%, and the FDS, which is about the proximal or the superficial, 40 to 50%. And so you see the FDP kind of keeps sliding, the FDS bunches up, and then eventually everything releases and slides distal. And so this right here is the level of the A1 pulley. And so you'll see what's bunching up is essentially underneath that A1 pulley proximally. And so what I would say in this evaluation, in this area, is that there's thickening in the FDS tendon and hypoechogenicity. There's thickening of the A1 pulley, and then there's dynamic, triggering underneath the pulley, and we'll kind of go through that at the report portion at the end. I'll just mention a couple of other examples. And so with a triggering finger, it doesn't always look the same. So it does not typically, or does not always look exactly like this. And so sometimes it'll be, a really symmetric snap. And so this one, there's no significant bunching of the FDS compared to the FDP tendon. So you don't always see that same sort of finding. You can also have situations where you have kind of some more kind of focally advanced kind of synovial adhesions or thickening on the superficial or deep aspect of the flexor tendon. And so they try and pass through like a relatively normal looking A1 pulley, but they can't. There's something sticking there. And so you see that kind of thickened tissue. The tendons look pretty normal centrally, but superficial and deep, they don't. And the A1 pulley looks normal, but this person still has a triggering finger, just a little bit different of pathophysiology. All right, and so just going through those, like we went through briefly up here with the flexor tendon kind of conformation. And so at the level of the metacarpal, you'll see that it's really kind of with differential movement, there's two tendons. One is just sitting on top of the other, and that is their appearance here. And that remains the same underneath a normal A1 pulley. As you go distal, you'll start to see, and this is a little bit more obvious with dynamic evaluation than just static pictures, but you'll start to see there's kind of an ovoid tendon here and another one here. And then there's the FDP tendon here. And so this is where the FDS tendons are starting to essentially split into two and separate. And then they continue to separate here. And so this is starting underneath the A2 pulley. And what you'll see is these flexor tendons start to wrap around and then now are wanting to be deep, and then they're going to head down towards their insertion on the middle phalanx. All right. After the flexor tendons, I'll move on to the pulleys kind of more specifically. And so, this is a question I was thinking of this morning. I had always assumed this was a short axis view of the A1 pulley, but I actually think it's a long axis view when you think about the fibers. And so with this view, you get a lot of shadowing on either side, typically with a trigger finger. And so when you get to like a normal A1 pulley, let's see, when you get to like a normal A1 pulley, you have a small amount of shadowing on either side. When you get to a really thickened A1 pulley, which is this right here, you'll get a lot of shadowing. And so what you're looking for in this view is kind of what is the maximal thickness, and then you can decide whether to measure that or not. And there are some published values that would suggest that you have a trigger finger or not. And so 0.14 centimeters is a pretty substantially thickened A1 pulley. And you can see it's just not quite as clean on, I guess, the long axis view of the tendon and the short axis view of the pulley. It's just not quite as clean of a picture there. And so I typically take all my measurements in this axial plane. And, you know, a normal A1 pulley is going to be kind of paper thin here. And so this is what a normal A1 pulley would look like. I then go down to the A2 pulley. Once again, I'll get that kind of axial image here, and, you know, look for any A2 pulley thickening or any A2 pulley tears. And then once again, I'll kind of get the short axis A2 view, I guess the long axis view on the tendon. And that's going to be kind of centrally located right over that middle phalanx, you know, here. After that, I'll move on to the digital neurovascular structures. And so I'll kind of scan them essentially from where they bifurcate in the web space all the way down to the kind of the most distal aspect I can see them. And I'll specifically pay attention to both the radial and the ulnar neurovascular structures. This is, you know, important in two aspects. One, if you plan any procedures, it's good to know where they are. But two, if you're doing any digital evaluation for something other than trigger finger, like a tendon laceration or nerve laceration, you want to pay pretty close attention to those. The collateral ligaments, I would say these are kind of optional to some degree. It really depends on what finger you're scanning. So when you're scanning like the middle and ring finger, it can be pretty difficult to get a good collateral ligament view at the MCP joint. When you're scanning the index and small finger, you can definitely see them. The thumb, you know, they're very important. But you can also look at them on the DAP joints. Those are kind of as indicated sorts of structures. So looking at the MCP joint, so proximal is going to be to the left here, and distal is to the right. And so you'll see that ligament footprint and then extending across onto that proximal phalanx insertion. And you can go ahead and do stress testing on these, and you can compare it to the other hand, and that's usually a pretty good indication of, you know, is there any ligament pathology there. All right, so from a summary standpoint, you know, for our patient, she really had some A1 hypertrophy, thickening of the A1 pulley. She had flexor tendinopathy, which preferentially affected that FDS tendon. She had dynamic triggering. And so, you know, this is a pretty clear-cut case of a trigger finger, but it is not always that clear. And so I'm just going to kind of go through the three things that I typically am thinking of when someone comes in for kind of like a catching finger sort of evaluation. And so one, I'm looking for that synostotic synovitis or the trigger finger. You know, that's the normal A1 pulley, the abnormal tendon, or abnormal A1 pulley and a possibly abnormal, possibly normal tendon. I'm looking for extensor tendon dislocation, and that's at the MCP joint. Typically is ulnar directed, and that can be either traumatic or atraumatic. And then I'm also looking for lateral band subluxation. And so for the extensor tendon dislocation, you know, we talked about the sagittal bands, you know, briefly, that they kind of wrap around and attach to the volar plates. And what can happen is, you know, these can either traumatically tear, where you get this extensor tendon dislocation, or they can kind of stretch. And so you can kind of have this kind of subluxation or dislocation without a complete tear. And so, you know, this is that sort of evaluation. So the extensor tendon was centrally located. And when they go into finger flexion, that extensor tendon is going to dislocate ulnar and kind of perch off the side of the metacarpal head instead of staying centrally located like it should. And so these kind of grade 2, which is what this is right here, this particular video is kind of a grade 2 of this subluxation. These typically don't cause a lot of snapping. They may feel like a subtle snap, but when people get these kind of full tears, these acute traumatic tears, or if they're having this grade 3 kind of subluxation, they can really snap and they can cause kind of a really significant triggering sort of phenomenon. And these are oftentimes clinically apparent, but not always super clear. And so, you know, ultrasound can really help confirm that diagnosis and can see if there's coexistent flexor tenosynovitis or synosine tenosynovitis in addition, if there's one problem or two. The other thing that you can look at, is lateral band subluxation. And so this is the PIP joint right here. And so I'm just going to kind of scan in this long axis plane and relative to the central stiff neck extensor tendon. And you'll see these osteophytes popping up along the joint margins. And these osteophytes, combined with some laxity and some of the soft tissue, can result in these lateral bands subluxing. And so they can be really hard to dynamically see because the snap occurs very quickly. And so what I typically will do is I will take these videos of the snap, and then I'll play them back on my machine kind of in slow motion and watch that snap occur. And I think the next video is maybe a little bit more apparent. And so you have dorsal to left, and so you have this soft tissue when they go from flexion to extension, snaps over, and then when they go back, that tissue is going to snap back. And so it's a lateral band subluxation. All right, so that kind of completes my, evaluation of a kind of catching finger. And so just to kind of really briefly summarize some of the literature, these are a couple of good papers that you can reference. And really, if you're looking at an A1 pulley that's thicker than 0.6 or so, that's a pretty good cutoff between a normal and a trigger finger. Once you get greater than 10, it definitely is very apparent. Most of the time, the A1 pulley of hyperemia, I'll admit, I don't look for hyperemia a lot in the A1 pulley unless it's not perfectly clear to me. You'll see thickening and rounding of the flexor tendons, particularly the FDS, blunting of the tendon margins, and then you can get a bunch of other things, tenosynovitis, loss of the normal echogenic pattern of the tendons, and then tenosynovial fusion. And then the last portion of this presentation is to kind of go through the ultrasound report. And so this is really where I think I've seen the most difference, through this case series of how people describe things and how they do things. I typically do mine the same way every single time. I do my exams the same way every single time. And that way you don't miss things. And so I always put the referring provider if it's applicable. I put what procedure we're doing, so complete diagnostic ultrasound of the right middle finger. I put my indication, my comparison, so if there's any radiographs, an MRI, previous ultrasound that I'll compare to. And then the next thing I put is my impression. And so, for this particular patient, my impression would be right middle finger. And one of the hand surgeons I work with, early on when I started after fellowship, kind of said, like, please don't use digit 1, 2, 3, 4, 5. Please refer to the fingers as their proper names, so we always are clear on what you're talking about. And so I've switched to using all kind of the proper finger names, so thumb, index, middle, ring, and small. And so right middle finger, A1 pulley hypertrophy with flexor tendinopathy and dynamic triggering of the flexor tendon through the A1 pulley. And then I'll add in my editorial sometimes at the end, which reproduces the patient's typical symptoms. This is consistent with synosine tenosynovitis. And the reason that I sometimes will add that editorial is sometimes you'll have patients that have multiple areas of pathology. And in the surgeons, that I work with and myself, we want to know which of these things is causing their symptoms. And so if I can figure out, which of the things reproduce their symptoms appropriately, then I'll add that editorial in. I'll indicate what my technique was, and so what machines or transducers I was using, and how I imaged them, how they're annotated, and where they were saved and uploaded. And then this is where I've seen the most difference between people, and this is really your preference. And so I like to organize things by structure, and that way I don't miss things as I'm going through my list. And then I also have athletic trainers scribe my diagnostic ultrasounds as I'm doing them. And so this helps them always know exactly what I'm talking about and not having to try and switch back and forth between structures and adding things into a paragraph. And so I list all of my things. And so it'll say the extensor tendon is normal. Specifically, there's no sagittal band injury, no extensor tendon dislocation. And then, the joints look normal. The flexor tendon, this is just an editorial of what the impression ultimately ended up being. I'll indicate what the A1 pulley and A2 pulleys look like, the digital neurovascular structures, and then any additional structures that I add in, I will put on the end. And so this is kind of what my overall report will look like in the note. And then just a couple of takeaways. I know we only have a couple minutes left, but I always follow a protocol, and I think this is super important. Is always follow your protocol, and it doesn't matter where you're scanning. If you're just doing a limited exam, right? You just want to see, do they have patellar tendinosis? That's one thing that's easy. You go right to the thing of pathology or the suspected pathology. But when you're trying to do a complete examination, I'll always get people saying like, well, why are you starting at the top of my hand? Why are you looking at the back of my finger? They said they have a trigger finger. It's on the other side. And so don't get lured in by the diagnosis you initially suspect. Go through your protocol, examine all the structures and all the appropriate planes, and get to what you get to whenever it comes through your protocol. If you just jump right to the thing, you oftentimes will forget to do the other things beforehand. And know the anatomy well. The fingers can be extremely difficult to ultrasound dynamically, and sometimes it just takes a lot of practice, especially with the extensor tendon dislocation. The lateral bands are extremely difficult, and the flexor tendon can be difficult depending on the patient and kind of your machine. And then, I'll always end these with kind of one of the takeaways I took from residency was from Dr. Weber, and he always just said, see what you look for, and you look for what you know. So the more things you know, the more things you can look for, the more things you can see, and the more accurate you are in your reporting of pathology. All right, and I'll end it there, and then any questions you have.
Brennan, that was a really, this is Doug Hoffman, that was a really excellent presentation. You absolutely just nailed all the highlights. I'm just going to kind of underline a couple of them. I see a lot of these. And I think, as you allude to, ultrasound is absolutely a game changer when it comes to hand disorders. And the most common cause of a failed trigger finger open release, I would say failed, that it continues to snap, is a misdiagnosis, that it isn't a trigger finger. And there's a number of people that have been sent for an ultrasound for post-trigger finger release, and it's not a trigger finger. So in that light, you just absolutely highlighted the two most common differentials, and that was the EDC dislocation. And I always check for that, even if the trigger finger is obvious in older people, and then sublux and lateral bands. I'll also just add that I've seen probably 3 or 4 cases of internal subluxation of the flexor tendons. So they actually switch, almost like the perineal tendons, they'll switch upon themselves, and usually occurs at the desiccation or when the FDS goes through the FDP. And then some people present not with triggering, but just difficulty with flexing their hands in older people. And it's always been, thought of as arthritis, but really often more in diabetic individuals, they have 3 or 4 trigger fingers on the finger, and they're just not actually getting stuck, but they hurt with flexion, and you can demonstrate, that the tendon is not sliding through with finger flexion. I'll just also comment that, again, just you really outlined it well, but trigger fingers have a look at them. And so I think of the A1 and A2 pulleys as a complex between the A1 and A2. And so while you did show a case of almost a normal non-thickened tendon, but it was still triggering, that's pretty rare. And right away, you can kind of look at that complex, A1, A2 complex, and you can see those changes. A1 pulley cysts are common. I even see them on the A2, and they're not ganglion cysts, they're actually pulley cysts. And then the last comment I'll make is that when you do a dynamic maneuver, which is just absolutely essential with evaluating the hand structures, with trigger finger, if you passively flex their finger, which you sometimes have to do because they don't want to actively, you're actually pushing the tendon through the pulley, versus when the patient is triggering and they're actively they're pulling the tendon through the pulley. And it actually results in some people in the differences of whether it triggers or not. So I try to get the patient to try to actively pull it, but sometimes I'll just help guide them so my ultrasound doesn't slip off and I get the dynamic image. So I try to have the patient actively flex rather than me passively, so I'm not pushing the tendon through, but they're pulling the tendon through. But again, that was a really great presentation. And there's some areas where the protocols just aren't as clear. And I think you really nailed that protocol where, you start with the joints, you go with the extensor tendons, because we all want a tendency to go right to the pathology. And as you point out in your talk, Brennan, that, stick to your protocol. Don't get fooled by going right to where you think the tendon is torn or the pathology is and miss other things. So, you really just nailed a really nice talk.
Thanks, Doug.
Were there any other, any other questions? All right, well, everybody have a good Friday. I think as Ryan said, that we start the fellow presentations in 2 weeks. Looking forward to those. And again, Brennan, thanks for just a really great talk.
All right, thanks everyone.